In the first webinar, we looked a little bit at some of the basics of HIV, including the life cycle of HIV, some of the common lab values we look at when we're treating HIV, as well as all the different medications we have on the market, how they work, and where they inhibit various spots of the HIV life cycle. In this webinar, I want to look some at the current guidelines we use here in the US and what these guidelines say about how to use these HIV medications, such as when to start them and when we might need to change them. There are multiple guidelines available from multiple different organizations around the world. For the sake of this presentation, the guidelines that I'm going to focus on are the U.S. Department of Health and Human Services guidelines. These guidelines are the ones we use most commonly in our current clinical practice and provide lots of information on how to treat HIV here in the U.S. These guidelines address multiple different topics. Some of the topics they talk about are laboratory testing, when to start treatment, what medications are best used when starting someone on treatment for HIV, when we might need to change therapy of someone who's already on medications, specific treatment that we look at in certain populations, such as people that are pregnant or people that may have other types of infections, as well as side effects from medications and drug interactions. For the sake of this webinar, the three main things that I'm going to focus on are when is it the appropriate time to start someone on medications for HIV, what is the best type of medications to start someone who's never been on any HIV medications, and when are certain times when we might need to change someone's regimen or stop their regimen. So to begin with, I'll talk a little bit about what these guidelines say is the best time to start someone on HIV therapy. This slide represents how the recommendations for treating someone with HIV medications have changed over time. As you can see, the CD4 count is the predominant factor for determining when someone needs to be started on medications. Initially, we would only start someone on medications when their CD4 count was really low. When their CD4 count's low, they're more at risk for other types of infections, and thus they were considered to be more in need of treatment. Since we have better medications, medications with fewer side effects, and medications that are more tolerable, you can see over time the recommendations for when to start someone on treatment have changed. Currently, the guidelines recommend that all people be started on medications regardless of what their CD4 count is. In addition, the current guidelines have an additional focus on certain populations that may be more at risk and may need treatment even sooner. Patients that are pregnant, patients that have infections with hepatitis B, as well as patients that have HIV, which stands for HIV-associated nephropathy or HIV kidney disease. In addition, the guidelines state that patients that are at high risk of transmitting the virus to others need to be started on medications right away. As mentioned, this slide illustrates the current guidelines recommendations for when someone should be started on medications. The current guidelines recommend that everyone be started on medications regardless of what their CD4 count is. However, the strength of that recommendation changes based on the CD4 count. If a patient has a CD4 count less than 350, this is a very strong recommendation because there are multiple randomized controlled clinical trials showing that patients with CD4 counts less than 350 need medications or they're more at risk for having other types of infections, other types of chronic diseases, and are at higher risk of death. When you get patients that have higher CD4 counts, such as patients that have CD4 counts greater than 500, the recommendation is a little less strong, as this is mainly expert opinion that patients need to be started on medications. However, these guidelines will likely be changing soon, as there have been a couple studies that have come out recently showing that patients, even with high CD4 counts, are at risk for other types of diseases due to the virus causing damage to the heart and to the kidneys, and we'll talk a little bit about these studies here in a minute. In addition, the guidelines state that patients that are pregnant, patients that have had AIDS-defining illnesses, such as other type of infections like pneumocystis pneumonia, need to be started on medications. Again, patients with HIV kidney disease and patients that have co-infections with hepatitis B need to be started on medications right away. In addition, the current guidelines recommend that antiretroviral therapy should be offered to those patients that have a high risk of transmitting the virus. These patients include patients that are in current relationships with heterosexual partners, or they may be at risk for transmitting to other groups, such as IV drug users that may be needle sharing with other people. Patients started on antiretroviral therapy should be willing and able to commit to treatment and should understand the risks and benefits of therapy and the importance of adherence to medications. We'll talk a lot about adherence and how adherence relates to the virus developing resistance to medications during the live training. But the guidelines point out that even though a patient should be started on medications based on the recommendations, if the patient themselves is not willing to start medications, giving a patient a prescription for medications when they're not ready to take them could actually be more detrimental in the long term. If the patient starts medications and they take it every other day and they're not very adherent with the medications, they could develop resistance and actually cause more damage than just having not started the medications in the first place. When looking at the guidelines over time, we have always weighed the risks of starting treatment early versus the benefits of starting treatment early. Some of the benefits for starting a patient on antiretroviral medications, regardless of their CD4 count, are that when we start a patient on medications when their CD4 count is still high, then we can maintain that high CD4 count and we can prevent the virus from damaging the cells in the first place. In addition, by starting the medications early, we can prevent HIV from causing other damage throughout the body. When HIV damages the CD4 count, the patient becomes more at risk for other types of infections. In addition, allowing the virus to replicate unchecked causes this low-level amount of inflammation throughout the body. This inflammation has been shown to cause all sorts of damage ranging from heart attacks to kidney disease to eye damage. In addition, if we start a patient on medications early on in the infection, then we can suppress the virus very quickly. When the virus is suppressed, this person has less of a chance of transmitting the virus to someone else. One of the most important studies to come out recently showing the benefits of starting a patient on therapy early is called the START study. This study was a large international study of over 215 sites in 35 different countries. In this study, about 4,500 patients with CD4 counts higher than 500 were enrolled. These patients were split into two different groups. Half the patients started antiretroviral therapy right away. The other half of the patients were not started on antiretroviral therapy until their CD4 count dropped below 350. The results of this study showed that patients that were started on medications right away had fewer serious adverse events. Even though the patients that were started on medications later in therapy, while their CD4 count is 350, they're still not at risk for opportunistic infections from bacteria and viruses in the environment. Delaying therapy and allowing the virus to continue to replicate caused damage to the heart, to the kidneys, and to the eyes, as well as numerous other parts of the body. And thus, these patients where therapy was delayed were at much higher risk for these various types of adverse events. One of the other major benefits in starting treatment early is that you can increase the CD4 counts to larger numbers. This is another study showing patients at different levels of CD4 count when they're started on medications. You can see if a patient has a lower CD4 count when they start medications, the increase in the CD4 count is not as great as if they had been higher when they started medications. As you can see, patients that had less than 50 CD4 cells, their CD4 count only increases to about 400, whereas patients that had higher CD4 counts to begin with have a high increase and their CD4 count will plateau at higher levels. In addition, if you wait longer to start patients on medications, patients that are older, patients that were greater than 50 years of age, had a lower overall increase in their CD4 count. So not only does delaying treatment decrease the total amount of CD4 count that you can increase, but also age will have an impact on how much the CD4 count increases. While the treatment guidelines in most major studies do encourage starting treatment with all patients regardless of their CD4 count, there are still some risks associated with early treatment. When patients are started on medications, they always have the chance of developing side effects from the medications. These side effects can sometimes decrease the overall quality of life. In addition, when a patient is started on medications, there is a mental aspect that the patient must be ready to start medications. Getting patients prepared to take a pill or two every day for the rest of their life can sometimes be a little bit of time consuming, and the patients sometimes need time to fully grasp the importance of the medications and why they need to be taking them. In addition, the longer a patient is on medications, they can sometimes develop a pill fatigue, which is just a little bit of depression when it comes to having to take a medication every day. If a patient develops this and sometimes starts skipping doses or missing doses of the medication, then they can develop resistance, and the medications won't work against the virus anymore. The longer a patient's on medications, the more chance they have of developing resistance and losing that medication. If the patient has developed multiple resistances to multiple different types of medications, then we may have to use more complex regimens with more pills that have even more side effects. Now that we've talked some about what the guidelines say in regards to when to start someone on medications, we'll look next at what the guidelines recommend for first-line regimens. What medications are we actually going to start these patients on? There are currently 5 first-line treatment regimens in the DHHS guidelines. 4 out of these 5 regimens are 2 NRTIs paired with an integrase inhibitor. The 5th regimen is 2 NRTIs paired with a protease inhibitor. And we'll look a little bit about these different regimens on the next slide. Four out of these 5 regimens have tenofovir and emtricitabine as the NRTI backbone of the regimen. These 2 NRTIs are then paired with one other medication to make the 3-drug regimen. The 5th regimen has abacavir and lamivudine as the backbone of the regimen. These NRTIs are then paired with one more medication to make the 3-drug regimen. If you take tenofovir and emtricitabine and combine it with dolutegravir, our integrase inhibitor, that's the first regimen. Tenofovir and emtricitabine paired with raltegravir, another integrase inhibitor, is the second one. If you take tenofovir and emtricitabine and pair it with darunavir, our protease inhibitor, and ritonavir, the booster to increase the blood levels of the darunavir, that's the third regimen. Tenofovir and emtricitabine co-formulated with alvategravir and cobicistat, another integrase inhibitor, that will make up the 4th regimen. All 4 of those medications are co-formulated in the medication Stribild. Finally, abacavir with dolutegravir, an integrase inhibitor, makes up the 5th regimen, and that's Triumec. So you have 4 regimens that each involve 2 NRTIs plus an integrase, and then you have one regimen which is 2 NRTIs plus a protease inhibitor. You can see that these regimens range anywhere from 1 pill a day to 3 pills. In addition, the guidelines have a list of numerous other recommended regimens that could be considered in patients under different circumstances. We have regimens with NRTIs, 2 NRTIs plus an NNRTI, as well as other protease inhibitor-based regimens. This slide can mainly serve as a reference for some other possible regimens that we might use in patients under different circumstances. The circumstances that we use to look at when selecting the appropriate regimen for a patient consist of the patient's baseline resistance testing and viral load. If the patient's baseline resistance test says that the HIV has already discovered how certain medications work and found ways around them, then we obviously won't use those medications to treat the patient. In addition, certain medications have a higher barrier to resistance, meaning that the HIV has a harder time developing resistance to them. Sometimes we'll use these medications in patients that we may have some concerns about their anticipated adherence. If they're more likely to miss a dose or two, we may select one of these medications as HIV has a harder time developing resistance to it. In addition, different medications are used in patients that have kidney disease or heart disease, patients that are pregnant, and patients that have hepatitis co-infections. Also, we'll often review with patients what the side effects of the medications are, as some patients may prefer some side effects over others. In general, though, we'll try to choose the medications that have the fewest side effects overall. Also, if a patient's on multiple other drugs for other conditions such as blood pressure or cholesterol, we'll look at trying to pick a good regimen that doesn't have drug interactions with any of these other medications. In addition, we'll also talk with the patient about what their daily schedule is and when they have meals. We'll often select a regimen with food or without food that needs to be taken in the morning or in the evening based on what fits best into that patient's daily schedule and that patient's daily routine. When we're selecting a regimen for someone that's treatment experienced, it gets a little bit more complicated. We'll take all those same factors into account, but we'll also have to factor in additional resistance testing. If a patient's been on multiple medications in the past, and the patient has had the virus develop resistance to these medications, we may have to come up with more complicated regimens that have medications taken multiple times a day. In addition, if a patient's been on medications in the past and had bad side effects with those medications, we'll have to avoid those medications. If a patient's developed allergies to a medication, or if we know that they had poor adherence while on a certain medication, we may still avoid those drugs. Even though we don't know there's resistance, we may suspect that the virus has developed resistance based on the fact that the patient wasn't taking the medication every day when they were on it. In addition, current guidelines provide some recommendations on what not to start a patient on. As I mentioned a little bit in the first webinar, we never start a patient on just one or two medications. We always start them on at least 3 medications from 2 different classes. If we start a patient on just mono or dual therapy, then the virus can also often develop resistance to those medications, and then they won't work anymore. In addition, we used to start patients on 3 NRTIs at the same time with no other medication. We found that if we don't use at least 2 different types of medications, the virus can still develop resistance. Patients that were on triple NRTI therapy, that is 3 medications just from the same NRTI class, the virus would work and be suppressed for several years, but eventually the patients would fail that treatment and develop multiple resistances to the NRTI class. The DHHS guidelines also provide a large list of specific antiretroviral medications that should not be used in combination with each other. I provided a lot of them here just for your reference. The main reason why a lot of these medications are not used together is because the side effects from the 2 together are very severe and often prevent patients from adhering to the treatment. In addition, there are some combinations of medications where the medications have very similar chemical structures and can actually prevent each other from working because they work at very similar places in the HIV life cycle and bind very similar to the different enzymes in the HIV, and thus they can actually compete with each other and prevent each other from working. Now that we've talked about some of the common first-line regimens for treating someone with HIV, we'll look a little bit about when we might need to change someone's regimen to something else, and what the guidelines say about what to do in that situation. There are multiple reasons for why we might need to change someone's therapy. The first and most common is viral failure, and that's when the patient is on medications, the virus continues to replicate. This could be due to multiple things. Either the patient is missing doses of the medication and allowing the virus to replicate and develop resistance to the medications. Or it could be that the virus had resistance to the medications already and was just never detected during a resistance test. Could be that the patient is also having side effects to the medications. The medications are working, but the patient has intolerable side effects that's preventing them from taking the medications regularly and decreasing their overall quality of life. We'll often have to change medications due to drug interactions. If a patient is started on another medication that they need for another disease state that interacts with our medications. Also, if a patient develops a comorbidity, has some other disease state that comes up, we may need to change our medications so that we don't worsen that other disease state. Often we'll change medications, regimens, just simply to help the patient reduce pill burden. If a new pill comes on the market that is just a combination of older medications, we may switch a patient's regimen just to help cut back the number of pills they have to take. In addition, we'll change medications in pregnancy so that we don't harm the baby with certain types of medications. And oftentimes we may simply have to change a regimen based on the patient's insurance and how much the medication costs. As mentioned, viral failure is a common reason why we might have to change a patient's regimen. Viral failure is in essence a patient having a detectable viral load while they're taking medications. This can be caused by a number of different reasons. The most common is that the patient is actually not taking their medications how they're supposed to. Suboptimal adherence could be that they're skipping doses, taking the medication every other day, or that they're taking the medication inappropriately in that they may be taking it with food when they need to take it without food, or vice versa. Pharmacokinetic issues is another reason, and we'll talk a little bit more about that in another lecture during the live training. Possible drug resistance is another reason why a patient might have a detectable viral load when they're on medications. Either they weren't taking the medications appropriately and the virus developed resistance to the medications. Then even when they continue to take it appropriately, if the virus has developed resistance, it will continue to grow and replicate even in the presence of the medication. When we pick a new regimen for a patient, we take all these different things into consideration. If they weren't taking the medication, then we'll find out why. Maybe it was a side effect that we can manage with another medication or by switching the medications to something that maybe have a little bit more tolerable side effect. If the reason for viral failure is that the virus has actually developed resistance to the medications, then we'll change the regimen based on what resistance showed up and what medications we still have available. One question that a patient will often ask whenever we're changing their regimen is, can I go back to my old regimen if I need to? And the answer to that question depends on why we were changing the regimen. If the patient is being changed because they had resistance to the medication, if they were non-adherent to how they were supposed to be taking the therapy and the virus developed resistance, then we're not able to go back to that regimen once we switch them to the new one. Simply because the fact that the old medications weren't working anymore because the virus has figured out a way around them. If for some reason, though, we simply change a patient's regimen because of side effects, drug interactions, or a comorbidity, there is a chance that we could go back to the original regimen if the original cause for the change has changed or has disappeared. So for example, if a patient was having a side effect of an upset stomach with a particular medication, and then we switch to a new regimen, if they have even worse side effects with the new regimen, then we could go back to that first regimen most likely, just because the reason for the change was the side effect, not that the medication wasn't working. Same thing with comorbidities. A good example might be pregnancy. We may change a patient's regimen because we want to avoid a particular medication that might be bad for the baby, but once the pregnancy is over, we could go back to the original regimen. Because the medicine was still working, we just changed it for a different reason. Same thing with pill burden. We may change a patient's regimen just to simply cut back on the number of pills. But if for some reason the patient has intolerable side effects to the regimen with fewer pills, we could most likely go back to the first regimen. The only major scenario where we can't go back to the original regimen is if the virus has developed resistance to the first medications. One other topic that I want to discuss in this presentation is the concept of interruptions in therapy. There are lots of different situations when a patient is on therapy that they may have to stop medications. A common thing that we run into in our clinic is that they have some sort of lapse in their insurance coverage and they're not able to get the medications anymore. If at any time when a patient is on therapy, if they need to stop medications, it's important that the patient knows to stop all their medications at the same time. Sometimes patients, knowing that they may run out of medications or that their insurance may have lapsed, will sometimes try to space the medications out, where they take a pill every other day or every 2 or 3 days, thinking that having some medicine in their body is better than not having any at all. Well, this is actually not the case. When you have a patient that skips doses and spaces out their medications, there's enough medication in their body that the virus can see it and can study it and develop resistance to it, but there's not enough medicine in their body that it's actually keeping the virus suppressed. Therefore, if for any reason a patient needs to have an interruption in therapy, it's important to tell them to take all their medications every day just as prescribed right up until they run out, and then stop them all at the same time. We try to avoid interruptions in therapy because they can cause some other side effects. Obviously, the virus will continue to replicate and grow while they're off medications. Patients with hepatitis B co-infections may also have flare-ups if they need to stop medications for any reason. If when you're talking to a patient, you find out that for some reason they've had to stop medications or they have an interruption in therapy, it's always important that you refer them back to their medication provider, that they see their doctor, and that they discuss this with their doctor so that the doctor is aware of what's going on in their patient's treatment. Initially, a couple years ago, we had this idea of a drug holiday, which is essentially an intentional interruption in therapy. If we had a patient that had a strong immune system, a very high CD4 count, but was having a little bit of side effects or maybe even just pill fatigue from taking medications every day, we thought, would it be possible to stop medications in this patient and just wait for their CD4 count to maybe go down a little bit and then restart them on medications? Maybe give them a couple months break from the medications before needing to start them back up again, as long as their CD4 count remained in a healthy range. This was a good theory, but the short answer is that this is not actually something that's good for the patient. And there was a major study that showed why this wasn't a good idea. That study was called the SMART study. And in essence, what this study did was it took about 5,400 patients. Half these patients took their antiretroviral medications every day and didn't have any interruptions in therapy. The other half of the patients, they told them to take their medications up until their CD4 count was greater than 350. Once their CD4 count and their immune system was that strong, they were allowed to stop their medications until their CD4 count dropped to about 250. When it got to that weaker state, they would start taking their medications again. What we found out from this study was that even though the patients in the second group, they had a strong immune system throughout the entire study, but the times when they were off medications, which allowed the virus to grow, the virus was causing damage to other parts of their body, and the inflammation was damaging things like their heart and their kidneys and their stomach. Patients in the other group had a 2.5 times more likely to have some sort of clinical event, such as a heart attack, and they were even more likely to die than the patients who just simply stayed on their medications continuously. In summary, here are a couple major points that I'd like you to take away from this presentation. First off, all patients should be offered antiretroviral medications regardless of what their CD4 count is. This keeps their immune system strong and prevents them from having more risk of adverse effects from the HIV virus replicating and causing inflammation in their body. Second, treatment regimens should have at least 3 active medications from at least 2 different classes. 4 out of our 5 first-line regimens are 2 NRTIs plus an integrase inhibitor. Third, all the regimens that we use for a patient should be designed to fit that patient, based on other symptoms that they may be having, other comorbidities they may have, or just to fit their daily routine, such as when they have meals and when they wake up and go to bed. Finally, interruptions in therapy should be avoided. Anytime that a patient is off medications, they're at risk for having adverse effects from the virus causing damage in their body. Thank you for taking the time to listen to these 2 webinars. As I mentioned at the end of the first webinar, if you have any questions regarding this material, please write them down and bring them with you to the live training. We'll review some of this information at the start of the training and can clarify any questions that you might have. Also, please don't forget to take the small quiz after this webinar. It covers a couple basic questions just to make sure you grasp this information. Thank you all again, and I look forward to seeing you here in a couple weeks.